A very good evening to everyone. I am Rohit Kohli, and on behalf of the NASPGHAN Foundation and my co-chair, Dr. Miriam Voss, I would like to welcome all of you to tonight's webinar. This webinar will focus on a few of the current controversies surrounding the diagnosis and treatment of fatty liver disease in children. I would like to now go over a few important housekeeping facts. First off, I would be amiss if I did not thank Amy Manella and the NASPGHAN Foundation for sponsoring this event, and also to Synergiva Biopharma, which provided support for tonight's program. Secondly, as you can see on your display window, below the main window within which you see the slides, there are a couple of interactive areas. During the course of this webinar, we will be conducting 2 participant polls. When it is time, the poll answer options will be shown in this interactive area. You will be prompted to pay attention to the same. Also notice that under the polling area, you may submit questions at any time during the webinar. At the very end of our presentation, the faculty will answer these questions submitted from the participants. The number of questions, of course, that can be entertained will be dependent on time available. May I have the second slide, please? I would now take the opportunity to introduce our faculty. Dr. Miriam Voss is an assistant professor at Emory University and research director of Health for Life at Children's Healthcare of Atlanta. She and I will be co-chairing the webinar and help collate and select the participant questions for the panel to discuss at the end. Dr. Stavros Zantakos is an associate professor of pediatrics in the Cincinnati Children's Hospital Medical Center. She also co-directs this institution's Steatohepatitis Center and is the medical director of the Surgical Weight Loss Program for Teenagers at Cincinnati Children's. Dr. Stephanie Abrams is an assistant professor of pediatrics at the Baylor College of Medicine, Texas Children's Hospital. She is also the medical director of Camp Kana, which is a wellness summer camp for obese children. I myself am an associate professor of pediatrics at Cincinnati Children's Hospital Medical Center and also help co-direct this institution's Steatohepatitis Center. And last, but definitely not the least, I would like to introduce Dr. Jeffrey Schwimmer, who is a professor of pediatrics at the University of California, San Diego. He also directs the Fatty Liver Disease Clinic at Rady Children's Hospital, San Diego. Slide number 3, please. During today's webinar, we would like to accomplish the following objectives. We hope that by the end of the webinar, participants can list the most common demographics of patients with fatty liver disease, describe the constellation of signs and symptoms associated with this disease, and perform appropriate testing when called for. We would also hope that participants at the end of the webinar can describe the appropriate treatment methodologies available and refer patients to hepatologists when necessary. I would now like to hand the proceedings over to Dr. Voss, my co-chair.
Thank you, Dr. Kohli. Before we start the controversies, I wanted to briefly cover some terminology under the NAFLD umbrella. Nonalcoholic fatty liver disease, or NAFLD, is a spectrum of disease, and the term NAFLD is generally used to represent the full spectrum. NAFL, or NAFL, is also called steatosis, and it's the most common presentation of the disease. Non-alcoholic steatohepatitis, or NASH, occurs less frequently and refers to steatosis plus inflammation and hepatocyte ballooning. Cirrhosis is the most rare, but does present in children. Another term you might hear us use is fatty liver disease, which is typically understood as including the full spectrum of disease. And now it's my pleasure to introduce Dr. Zantakos, our moderator.
Thank you very much, Miriam and Rohit. So for our very first controversy, I'd like to begin on slide 5 with an area that lacks broad consensus. That is screening challenges in children with NAFLD, to screen or not to screen. On slide 6, we can see that there have been previous guidelines that have addressed this issue. 2 were published in 2007 and 2008 by the American Academy of Pediatrics and the Endocrine Society. These 2 guidelines emphasize screening at-risk children The AAP guideline recommended every other year screening of ALT and AST beginning at age 10 for children that are obese with a BMI greater than or equal to the 95th percentile or overweight if cardiometabolic risk factors are present. The Endocrine Society guideline recommended screening children who are overweight with a BMI greater than or equal to the 85th percentile with an ALT. However, the Endocrine Society guidelines did not specify the frequency or the age to start screening. Next slide, please. On slide 7, the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition recommendations are presented. In a 2012 position paper, the Hepatology Committee of ESPGHAN recommended that NAFLD should be screened in overweight or obese children with abdominal ultrasound and liver function tests. Again, there are two important caveats to consider here. The guidelines do not specify frequency or age to start screening, and there are no well-established norms for waist circumference values in most populations of children. Slide 8 shows the most recent guidelines to address this issue, which were issued jointly by the American Association for the Study of Liver Diseases, the American College of Gastroenterology, and the American Gastroenterological Association. In their 2012 clinical practice guideline, they refrained from making any formal recommendation to screen due to a paucity of evidence. Again, a caveat to consider here, these guidelines are really evidence-based whenever possible, and when such evidence is not available or inconsistent, were made based on the consensus opinion of the authors. And in this case, the authors of this paper were predominantly hepatologists with no obesity experts and only one pediatric hepatologist represented. So I'd like to direct this question to Jeff next on slide 9. Ask Jeff, where do you stand in this screening debate?
Thank you, Stavra. So you can go to slide 10. And in order to answer the question about screening, we really need to break it down into several questions. The first, is NAFLD common in children? And the answer to that is yes. The prevalence is estimated to be approximately 9.6% of children aged 2 to 19 in the United States, which translates into somewhere between 5 million to 8 million children. Next slide, please. To put that into clinical context, give us a frame of reference, asthma, a common disease of children that we all know well, the Centers for Disease Control and Prevention estimate that there are about 7 million children in the United States with asthma. So NAFLD is on par with asthma in terms of frequency. Next slide, please. NASH, as Miriam spoke about, a subset of NAFLD, the population estimates are that 20 to 25% of children with NAFLD have NASH, or that would translate into about 1 to 2 million children in the United States. Next slide, please. The next question with respect to screening obese children is, are children with NAFLD obese? And we can look at this from data published in both clinical series as well as population-based data. In clinical series, anywhere from 50 to 90% of patients with NAFLD are obese. This is a large spread, but even at the low end, it still is the majority of children with NAFLD. On a population basis, our best estimates are that about 60% of children with NAFLD are obese. So it's not all, but it is the majority. Next slide, please. Are we likely to find ALT elevation in obese children if we look for it? And the answer there is yes, this is common, with estimates being that 10 to 20% of obese children will have an elevated ALT. Next slide, please. So, is NAFLD severe in children is the last question with respect to should we look for it. And if we look at clinical series of children with NAFLD who've had a liver biopsy, NASH has been present in those children in anywhere from a third to half of the cases. With respect to fibrosis, any amount of fibrosis is found in 50 to 70% of children who are biopsied for NAFLD, with advanced fibrosis being found in approximately 15% of children with NAFLD who have a biopsy diagnosis. Slide 16, please. And finally, not only is there the issue of histologic severity, but there are the clinical outcomes that occur at increased rates in association with NAFLD. And these can be divided into hepatic outcomes, such as end-stage liver disease and or hepatocellular carcinoma, as well as non-hepatic outcomes, the most important ones being diabetes, cardiovascular disease, and other forms of cancer.
Thanks, Jeff. You made some really compelling points that NAFLD is common and can be severe and certainly occurs at a high prevalence in obese children, and also that it's associated with numerous adverse long-term outcomes. So I'd like to turn to Stephanie now to pose the additional question that if you do screen, how should we be doing this?
Well, it's a great question, and I think that one of the first places to start is to really consider who is affected by this disease. We just discussed that overweight and obese children are more likely to be affected by this disease, and so that should be one of the first factors in consideration of who should be screened. There was a prevalence study that was performed by Schwimmer et al. That looked at autopsies in over 740 children and really tried to identify who is affected by fatty liver. And what they found was that the prevalence increased with age, so that an older teenager has a higher risk at having fatty liver. So you may have a higher suspicion for fatty liver disease in an older child rather than a young toddler. Additionally, when you think about fatty liver, we really consider this to be the hepatic manifestation of metabolic syndrome. So when we see an obese child in our clinic who may have dyslipidemia or other features of metabolic syndrome, that really should be a red flag to us and maybe make us consider to screen that child more actively. Additionally, family history may be something that comes into play and really sways you. If you have a parent who has been a transplant recipient for NASH, it's something to be considered. The other thing, you can see the graph here. When we looked at the autopsy study, we found here that Hispanics are more likely to be affected with fatty liver than an African American child. In fact, Schwimmer et al. Found that being a Hispanic child makes you 5 times more likely than an African American child to be affected by fatty liver. So it's important to consider race and ethnicity when you're considering who should be screened. Next slide, please. So how should we screen? Well, Stavra reviewed some guidelines that are out there, and currently liver enzymes, ALT and AST, are the most commonly used exams in order to identify someone with liver disease. And we really use ALT and AST to consider hepatocellular injury versus GGT or alkaline phosphatase, which are more cholangiocyte markers and would indicate cholestasis or bile duct injury. Additionally, when you look at the adult literature concerning alcoholic steatohepatitis, the adult hepatologists really look at an AST to ALT ratio and really see that that tends to be greater than 1. But in fatty liver disease, what we see is that the ALT is generally greater, and so our AST to ALT ratio is generally less than 1. One of the guidelines that we discussed already states that ultrasound should be considered as a screening tool. And we're going to cover more of these details later in our webinar, but the data really are clear that ultrasound is lacking in both sensitivity and specificity. It's important to consider also societal resources, and that doing imaging really takes time and money for society. Next slide, please. So what level of ALT is worrisome? I get this question from colleagues all the time. And there was a great study published by Schwimmer et al. In Gastroenterology in 2010, the safety trial, and they looked at the National Health and Nutrition Examination Survey. So this is great data obtained by the Center for Disease Control throughout all of the United States. And they really wanted to find what level of ALT is meaningful. And what they looked at were healthy weight boys and girls without metabolic derangement or liver disease, and they determined what was the 95th percentile for ALT for healthy boys. And they found that healthy weight boys in the 95th percentile would be 25, and for girls, 22. And they found that when you use these cutoffs in evaluating a child for liver disease, that you have a higher sensitivity in really identifying a child who has chronic liver disease. Slide 21, please. So we do have some limitations to our screening tools that are really recommended when trying to identify which child has fatty liver. ALT and AST are not a perfect screening tool, but it really is the best that we have currently. It's clear from bariatric surgery studies that there are many people that undergo bariatric surgery. They have liver biopsies at the time of bariatric surgery, and about a third of all of the adults undergoing bariatric surgery have NASH. And of those, more than 40% will have a normal ALT. And this just demonstrates that ALT really reflects hepatocyte injury and not necessarily apoptosis on a cellular level. So your ALT and AST may not be the perfect screening tool. But additionally, when we think about imaging, and will that really help us identify which child is at risk, we really need to know that imaging can't accurately tell the practitioner about the histologic features of inflammation or the stage of fibrosis. And again, we really should consider utilization of resources when considering utilizing these as screening tools on a population-wide basis.
Thank you, Stephanie. So on slide 22, I'd like to just briefly summarize what we've discussed so far. And essentially what we've heard is that while screening remains controversial, but recommended by some, there are some compelling themes to consider this. NAFLD and NASH are very common in obese children. NAFLD can be severe in children and can include advanced NASH and progressive fibrosis with really minimal to no clinical symptoms. Adverse health outcomes are associated with NAFLD and NASH. And elevated ALT and AST, though not perfect, are associated with NAFLD and NASH and can be used clinically to identify some patients. But to really fully address the screening controversy, I think we also need to discuss what to do when NAFLD is identified or suspected after screening. Next slide, please, on 23. So I think many of us often feel this way when we are considering what to do next with an overweight or obese child with a chronically elevated ALT or AST. We ask ourselves if we should pursue exclusionary testing, consider a liver biopsy, what imaging tests we ought to consider, if any at all, and whether there are any new biomarkers or panels out there. So on slide 24, in order to start this discussion, I'd like to present a common scenario we often see in our NAFLD clinic and open this up to our poll in a moment. Case 1 here is a child that has sonographic evidence of hepatic steatosis, but really not much else clinically that's concerning. She's 14 years old, she's white, and she's actually non-Hispanic, so a category of patient that many of us wouldn't particularly consider to be at really elevated risk. However, she does have an elevated BMI, and she has chronic mild generalized abdominal pain. As part of her evaluation for the abdominal pain, an ultrasound was obtained by her primary physician, which showed increased echogenicity concerning for hepatic steatosis. A liver profile also showed mildly elevated liver enzymes with an ALT of 36, an AST of 42, and a GGT of 31. So next slide, please. On slide 25, you'll see a participant poll. And here I'd like to briefly review the instructions for participating in the poll. In a moment, you'll see the poll question in the main window, and the multiple choice answers will be presented just beneath the slide along with a submit button. Simply make your choice and hit submit. We'll report the results of the poll in a few minutes. So to summarize this poll, in evaluating this 14-year-old patient with sonographic evidence of hepatic steatosis, you could A, pursue no further testing, she has presumed NAFLD, B, obtain exclusionary testing to rule out other causes of hepatitis, or C, none of the above. Again, we'll report the results of the poll in a few minutes. In the interim, I'll ask Jeff to give us his thoughts on this issue.
Thank you, Stavron. So to look at that case, I think the first question is, what does a positive ultrasound really mean? And we need to look at the total picture. So there's really two parts to this case. One, you talked about the ALT for this girl, which was 36. And so here I placed it the way one might see it in today's electronic medical record. And so if the normal range at an institution is, say, 5 to 40, then 36 won't be flagged, and somebody may not appreciate that there was an abnormality at all. If one were to use the cut point of 22, as Stephanie described, then in fact, for a girl, then in fact 36 is 164% of normal and would be flagged as high. With respect to the ultrasound, we also will see a huge variability, not only institution to institution, but even radiologist to radiologist, in how they report out an ultrasound. So one may see echogenic, consistent with fatty liver, or one may see echogenic impression, fatty liver, or one may see echogenic suggests fatty liver versus other hepatocellular disease. And that last one, that's probably the best of those. But how does ultrasound really work? Next slide, please. The principles by which ultrasound may be used to evaluate steatosis is based on high-frequency sound wave propagation. And it's important to keep in mind that steatosis, as well as iron, inflammation, fibrosis, will all change the propagation of sound waves, causing scatter and or attenuation. Scattering of the wave will produce more waves, more echoes returning to the receiver, or a, quote, bright liver. Attenuation of the wave will cause depth-dependent loss of signal returning to the receiver. And it's the detection of both scatter and attenuation of the sound wave that's inferred to represent steatosis. Next slide. So how good is this as a tool? To evaluate diagnostic performance, it depends in part what question one is asking, and there are two that are commonly asked. The first is really the question about making the diagnosis. And so there, it's really what's the positive predictive value of a positive ultrasound in an obese child. And the best available studies, if you take these and aggregate them, are that the positive predictive value of an ultrasound in an obese child is about 50%. If one wants to use ultrasound to grade the severity of steatosis, there have been several publications that have evaluated that outcome, or to be able to correctly classify steatosis as none, mild, moderate, or severe. The accuracy of that classification by ultrasound is only about 35%. So I would say that this particular case, the fact that this girl had a, quote, positive ultrasound means nothing to me, because the ultrasound is just as likely to actually show that the liver turns out to be normal, or that turns out to be fatty liver, or turns out to be something else. What about MRI? Next slide. A lot of enthusiasm for MRI as a tool potentially to evaluate steatosis. Here in the picture, what we see is a spectrogram from MR spectroscopy of the liver, more direct measurement. MRI is based upon chemical shift. And so what you can think about is that the magnet stimulates the hydrogen nuclei that are present in the chemicals within the tissue of this case, the liver, and that water molecules being smaller than fat molecules will experience a slightly different magnetic field. And MRI technology can exploit that difference to try to distinguish fat from water on an imaging study. So how good is that? Next slide, please. It's been shown that MRI is almost as accurate as spectroscopy. With respect to the ability to diagnose fatty liver, to say that somebody does or does not have, here there's no standardization of the threshold for diagnosis, and there are published values ranging anywhere from 1.8% for a liver fat fraction to as high as 9% for a liver fat fraction. So before this can be used as a clinical tool for diagnosis, there needs to be standardization based on appropriate validation studies. And then lastly, if one wants to grade the severity of steatosis, that data for MRI compared to biopsy looks quite promising, but the data are too limited at this point to be able to make firm conclusions or recommendations.
Thank you, Jeff. On slide 31, the next slide, I'd now like to share the results of our participant poll. For this poll, 20% of participants chose answer A, to pursue no further testing and presume that she has NAFLD. 63% chose to pursue exclusionary testing to evaluate for other causes of hepatitis, and 17% chose none of the above. On slide 32, I'd like to present another case, perhaps a more typical case, a classic presentation that we frequently see. In this case, a 10-year-old white Hispanic male presents to your clinic. He's severely obese for his age with a BMI of 32, and he clearly has, even by reference laboratory standards, elevated serum aminotransferase levels on at least 2 separate evaluations more than 1 month apart. Next slide, please. On slide 33, again, you'll see a participant poll question in the main window. The multiple choice answers are presented here on this slide, and there's a submit button below. Simply make your choice and hit the submit button, and again, I'll report the results of the poll in a few minutes. The choices for this participant poll include A, in this Hispanic male, my next step would be to make a presumptive diagnosis of NAFLD and recommend weight loss. B, I would obtain exclusionary labs and imaging study to rule out other causes of hepatitis. C, I would obtain the labs and imaging study and then perform a diagnostic and staging liver biopsy if the diagnosis is unclear after testing returns. And D, I would do the labs and the imaging study and then perform a liver biopsy if I suspect NASH and the enzymes remain elevated. Again, I'll report the results in a few minutes. And in the interim, I'm going to ask Stephanie, how would you evaluate a child like this?
I really love that case because it really is a typical child who presents in clinic so frequently with the ALT just 2 or 3 times the upper limit of normal, using 22 for girls and 25 for boys. And as you can see on slide 34, we would definitely consider working this child up for other elements of metabolic syndrome. Looking for dyslipidemia, diabetes, and other features of metabolic syndrome. But additionally, we would want to rule out other causes of chronic hepatitis in a child of this age. And those would include ruling out hypothyroidism, assessing for Wilson's disease, alpha-1 antitrypsin deficiency, autoimmune hepatitis. And really, I would encourage everyone to let the clinical picture guide you with regards to your serologic workup. This child may have some abdominal pain or bloating, so you might want to consider screening with a total IgA and a TTG IgA for celiac disease. Additionally, you might consider that if the elevation of liver enzymes has been of a shorter duration and maybe some other symptoms, you might want to consider an infectious etiology, and you might be sending off some of those serologies. You could also be considering sarcoidosis. Maybe it's an African-American teenage female, and you might want to be considering that with regards to elevated liver enzymes. So it really is important to let the clinical picture guide you when choosing your serologic workup. Next slide, please. So a big question is, when do we do a liver biopsy? And an important thing to consider when working up a child for fatty liver is that NASH can really not be diagnosed without a liver biopsy. It's a histologic diagnosis. And so when are you doing a liver biopsy? It's really to identify the etiology of chronic hepatitis and the severity of liver injury. So in part, you would want to do a liver biopsy when you want to rule in the diagnosis of fatty liver. It's important to consider that an ALT does not pick up which child has advanced fibrosis or cirrhosis. Only a liver biopsy can really do that for you. It's also important to consider that children can have elevated liver enzymes, but really under the microscope you can see very mild injury histologically. So when considering why to do a liver biopsy, it's really important to consider our other options. So I'd like to present some case studies for you guys. Slide 36, please. To really drive home the point that there are no reliable surrogate markers for inflammation or fibrosis, I wanted to share a case with you guys. This is an 11-year-old Asian female. She had no significant past medical history, presented with elevated liver enzymes and some constipation. Of note, mom is from the Philippines and father is Caucasian, but had one grandparent who was American Indian. And the child had a BMI that was 97 percentile for age and sex. And as you can see, the ALT was 115, AST 55, with a GGT of 25, a normal albumin and bilirubin, normal platelet count, and a normal INR at 1.0. An ultrasound had been performed and demonstrated hepatic steatosis with generous hepatic and splenic sizes, but otherwise the exam was really only remarkable for nuchal acanthosis nigricans. Next slide, please. This child's biopsy showed that she had NASH-related cirrhosis with a NAFLD activity score of 5 of 8. So this is just one case where you would say, wow, the platelet count was normal, the INR was normal, and you might be surprised to find that this is a child who's only 11 years of age but has cirrhosis. So again, if you had not done the liver biopsy, you really wouldn't know that. Next slide, please. So why is liver biopsy better than an ultrasound for diagnosing fatty liver disease? Well, here I was consulted by one of my colleagues who had taken care of this child with inflammatory bowel disease for many years. This is a 14-year-old white female who had a history of UC, diagnosed at 5 years of age, and actually had sclerosing cholangitis diagnosed at 6 years of age. And she had been maintained in remission on ursodiol and mesalamine for many years. And she called into the office complaining of URI symptoms and some right-sided abdominal pain that led to serologic and radiologic evaluation. And as you can see in the table, at the age of 6, when she was diagnosed with PSC, her ALT and AST were in the upper 200s with normal albumin and INR. And once she maintained remission and was on ursodiol for many years, she had normal transaminases with an ALT less than 20. And 9 months earlier, we saw that her ALT had been 11, AST 10. And currently, she presented with the ALT 315 and AST of 310. Next slide, please. On ultrasound, my colleague had found that she had a hyperechoic liver consistent with hepatic steatosis. And what you can see here is this was her growth curve. So he called me and said, well, listen, she's really gained a lot of weight over these last few years, and now she's overweight. Her BMI is 93rd percentile for age and sex, so I'm really concerned that this child has fatty liver. I performed a biopsy on this child. Next slide, please. And what the biopsy showed was chronic active PSC with bridging fibrosis. Again, there was no steatosis on this biopsy at all. So it's important to remember that a hyperechoic liver on ultrasound isn't always fat. It indeed can be bridging fibrosis or even cirrhosis. Next slide, please. So I think a lot of people are hesitant when they think about liver biopsy. You know, you feel like it's a very risky procedure. But the truth is, when you look at the studies that have been published in the last 5 to 7 years, liver biopsy is safe. You know, we have more than 500 children enrolled in the NASH Clinical Research Network, which is a UO1-funded consortium by NIDDK. And what we found is there have been no severe adverse events with more than 500 children that have been enrolled in the CRN. Additionally, there have been studies that have reported that interventional radiologists who are performing liver biopsies are actually proven to be as safe as those performed by us. Interestingly, there was an article published a few years back that did poll pediatric gastroenterologists, and what they found was more than a third of all pediatric GI doctors preferred to refer to interventional radiology for their liver biopsies. But in general, when you look across the board, the rates of bleed with liver biopsy are 0 to 0.1% with no serious adverse events. So some of my colleagues say, well, I feel good with doing liver biopsy, but not in obese children. You know, it's not safe when they're obese. Well, actually, the data states that pediatric obese patients really do not have any increased serious adverse events over normal weight or underweight children. And in fact, blind percutaneous liver biopsy had no increase in complication rate when compared with non-obese children. So it's important to consider that when we are evaluating a diagnosis that is histologic injury, a liver biopsy is really necessary. And in this case, we can demonstrate that liver biopsy is actually safe whether it's performed by us or whether we choose to refer these children to interventional radiology for their liver biopsy.
Thank you, Stephanie. Those are some very important points. On slide 42, I'm now going to show you the results of the participant poll. So for this Hispanic child with chronically increased liver enzymes, 11% of participants would make a presumptive diagnosis of NAFLD and recommend weight loss. 39% would obtain exclusionary labs and imaging to rule out other causes of hepatitis. 18% would also consider liver biopsy if the diagnosis was unclear. And 32% would consider liver biopsy if NASH was suspected. So I'm going to turn now on slide 43 to our very last controversy that we'd like to discuss tonight, and that is namely what treatments can we recommend to patients with NAFLD or NASH. And here again, on slide 44, I'm going to present one of my very own patients that I've been struggling with for the past few years. He's one of my more concerning and challenging patients. He initially presented to me at the age of 10 in January of 2009. And at that time, as you can see from his BMI, he was already very extremely obese with a BMI of 36.7. He had a markedly elevated waist circumference. His ALT, AST, GGT were clearly abnormal. He also had impaired glucose tolerance, but his hemoglobin A1C was normal on metformin, and he was taking some psychotropic medications at stable doses. Following him for 2 years, we became concerned in April of 2011. Even though his BMI had minimally decreased and he was making some efforts to lose weight, his enzymes had increased further. His fasting glucose had worsened, and we decided to re-biopsy him. On the next slide, on slide 45, you'll see our biopsy results. So at the age of 10, this young man already had very prominent steatosis, and he had stage 1C to stage 2 fibrosis. However, 2 years later, at the age of 12, he had rapidly progressed to stage 4 fibrosis. And he's particularly concerning to me because he has made some efforts to lose weight. Now, he has not been in an intensive weight management program due to social reasons. They haven't been able to participate in our program, the more intensive program. But I wanted to ask you, Stephanie, what are your thoughts on weight management? Can it even work?
Well, it's a great question. And I really think that when we look at a child who has NASH, we have to consider that weight management is absolutely necessary. We know that this was a major player in the evolution of the disease, and we're really ethically obligated to treat the underlying cause of the disease. We know that these kids are at risk to develop hypertension, diabetes, and other severe comorbidities. So really, when you think about these children, you really want to aim for a comprehensive behavior modification program because that is really what's been shown to have the highest success in improving weight status for a long term. When you look at some Canadian recommendations with regards to the evaluation and management of obese children and adults, they actually recommend considering medication for weight loss. And in children, they recommend using orlistat for the severely obese child. So that is a modality that can be considered. Bariatric surgery has also been used as a treatment modality, and in the appropriate center where you really treat the whole patient and provide support groups and really have a full team evaluating and treating that child, bariatric surgery really could be a great tool for you in managing the weight of a child who has NASH. And it's really important to consider when guiding your patient through their weight loss journey that gradual weight loss is really what is recommended. You know, all of our kids want to do the biggest loser. They want to lose 20 or 30 pounds in a week. And it's really important to encourage slow, steady changes in behavior that would lead to gradual, continual weight loss, especially in the setting of NASH, where we know that a sudden or quick weight loss could actually accelerate progression from steatosis to NASH. Next slide, please. So I wanted to present to you a study that looked at physical activity and nutrition attitudes in children with NASH. There were 3 groups of Hispanic children. There were 20 children who had biopsy-proven NASH, and then there were 20 obese controls and 17 lean controls. And what we found was that children with biopsy-proven NASH consume significantly less fruits than obese and lean controls, and only a quarter of children with NASH eat at least 1 serving of fruit each day. They also report having less physical activity and a higher sedentary score. And interesting, when we looked who had the higher sedentary score, the children who had advanced fibrosis had higher sedentary scores. So this is kind of important, I think, as a practitioner because it gives you some insight into some children with NASH and what barriers you may be up against when really trying to tackle behavior modification and really trying to get kids moving with regards to behavior change in dietary intake and in exercise and activity levels. Next slide, please. So what is out there with regards to lifestyle intervention with behavior modification? And really what you find when you go through all of the literature is that there's a paucity of studies in children that truly have follow-up liver biopsies at the end of the intervention. Well, we've talked about here today that, liver biopsy is really the only way to know what is the status of the disease. Stavro presented a great case where really the ALT was relatively the same over the course of those few years. It was slightly increased before, but you were in the 100s and went to higher 100s, and you actually had severe increase in fibrosis. So you really want to see a final liver biopsy if we're going to say that a lifestyle intervention was really efficacious. We have many studies that have demonstrated improvements in BMI, insulin sensitivity, and body composition when you have some lifestyle intervention. And it's interesting, the adults have really gone further to look and say, well, is it what you eat? Is a Mediterranean diet the best? A low glycemic index diet the best? And there are some adult studies that show that it's actually calorie reduction with weight loss that really improves histologic injury the best. But again, we don't have a pediatric study that addressed that. Next slide, please. Here I want to give a shout out to our colleagues in Italy. They really did have a lifestyle intervention that had behavior modification that was aimed at achieving moderate weight loss to improve NAFLD, and there were follow-up biopsies, which is so key. This was 53 subjects, and they were ages 6 to 18 years of age on the whole, and it was mostly boys. And what they did was if it was an overweight or obese child with the biopsy-proven NAFLD, then they were given a hypocaloric diet, and if they had a normal BMI, they had an isocaloric diet. And they recommended moderate daily exercise for 45 minutes daily, and these kids had visits with a multidisciplinary team every 3 months. And what Nobili et al. Showed was that moderate weight loss could improve ALT and some fatty infiltration and necroinflammation, but there was no change in the degree of fibrosis. But this suggests that we really need to consider other modalities when we're trying to treat the child who has biopsy-proven NASH and NAFLD.
Thank you, Stephanie. So, Jeff, if weight management fails, or maybe it's not an option for a particular family or a patient, are there actually any valid pharmacotherapies that we can offer now?
All right, so on slide 50, I'd like to point out regarding pharmacotherapy of NAFLD that there are no FDA-approved therapies for NAFLD, period. And that's true in both adults and children. And thus, any treatment used, or in the case tonight discussed, is thus done so off-label. And it's also important to keep in mind, despite the urge to sometimes do something, to first do no harm. Next slide, please. So I'd like to start by talking about TONIC, treatment of NAFLD in children, a large multi-center study that was done through the NASH CRN and published in JAMA 2 years ago. In this study, there were 173 children with biopsy-proven NAFLD and a baseline ALT greater than or equal to 60 who were randomized into a double-blind placebo-controlled trial with 96 weeks of treatment of either vitamin E, 400 international units twice a day, or metformin, 500 milligrams twice a day, or placebo. The primary outcome of the study was change in ALT. Secondary outcome was histology. Next slide, please. Looking at the primary outcome, sustained reduction in ALT, what we see here is the outcome versus placebo, with the middle column being vitamin E and the column 3 being metformin. And there was no significant difference in the sustained reduction in ALT for either vitamin E or metformin. There was also no significant difference in changes in AST or GGT with either vitamin E or metformin. Next slide, please. With respect to secondary outcomes, the histologic features, each feature was looked at individually: steatosis, lobular inflammation, portal inflammation, ballooning degeneration, and fibrosis. And of these 5 histologic variables, the only one for which there was a difference was in ballooning degeneration. And for both vitamin E and metformin, there was significantly greater decrease in ballooning degeneration with those medications. Next slide, please. How much of a difference? What you can see here is that 22 of 58 children taking vitamin E and 22 of 57 children taking metformin, or 38 or 39%, had improvement in their ballooning degeneration score. So it was one feature out of 5, no improvement in steatosis, inflammation, or fibrosis. Next slide, please. So where does that leave us with regarding the issue of vitamin E? The AGA, AASLD, and ACG, in the guidelines that Stavros talked about earlier, they state that confirmatory studies are needed before vitamin E can be recommended in clinical practice. And I think it's very important to bear in mind that a large meta-analysis of vitamin E and mortality showed the following. With over 136,000 individuals, 9 out of 11 clinical trials that used a high dose of vitamin E, defined as 400 international units or greater per day, showed increased mortality versus placebo. They saw a dose-response relationship with the increase in mortality beginning above a dose of 150 international units per day. Next slide, please. Fish oil is something that there is also a lot of enthusiasm for its potential in NAFLD, and in part, this is due to the dyslipidemia that's common in children with NAFLD. There are at least 10 studies, either NIH-funded or industry studies, of fish oil supplementation for NAFLD that have been declared to clinicaltrials.gov between 2005 and 2011. There are very few data yet to be reported. Makes one wonder. And it's also worth bearing in mind that meta-analysis of omega-3 supplementation in over 63,000 individuals showed absolutely no benefit whatsoever on the things for which people think they take fish oil for, like mortality, heart attacks, or stroke. Next slide, please. So what else might there be? Cysteamine is based on the fact that the conditionally essential amino acid cysteine is a major limiting factor for glutathione synthesis, an important antioxidant within the liver. Unlike glutathione, cysteamine is a small molecule which can easily cross cell membranes. Cysteamine is currently available and used in the treatment of cystinosis. Next slide, please. A second-generation form of cysteamine, a delayed-release form of it, was used in a pilot study at UC San Diego in children with biopsy-proven NASH. And what we can see here in the blue or purple is that over 24 weeks of treatment, there was a reduction in mean ALT. Drug was stopped at 24 weeks, and that ALT reduction persisted over the next 24 weeks, which is very different than has been seen for other medications to date. You can see in green that BMI did not change over the course of that year, and AST also had a similar pattern to that of ALT. Next slide. So this, along with other data, led to the development of a clinical trial called Cynch, cysteamine bitartrate delayed release for the treatment of NAFLD in children. This study is actually using a third-generation form of cysteamine. Again, NIH-funded trial being conducted by the NASH Clinical Research Network. This study seeks to enroll 160 children. Here, histology is entry criteria. Children must have an NAS score of at least 4 to qualify for this study. It's a randomized, double-blind, placebo-controlled study, 1 year of treatment. Cysteamine, bitartrate, delayed release. We'll be using weight-based dosing. So one of the things that we learned from TONIC was problems with not having weight-based dosing potentially. And here the primary outcome is histology. We'll be looking at NAS improvement of at least 2 points.
Thank you, Jeff. On slide 60, I'm going to try to summarize some of the main points that we've covered today. I think we've made a strong case that NAFLD is very prevalent in obese children, and NASH is associated in particular with cardiometabolic risk factors, both short-term and in the long term. There remains no uniform consensus on screening at-risk children. Some experts, however, do recommend screening, so weight loss efforts can be intensified if NASH is present, while others cannot recommend given the absence of data on long-term benefits of screening. I think the jury's still out on the screening question. I think in part it might depend on what we think about weight management and whether it can be effective, and perhaps we can address that more in the question and answer period. The evaluation for other causes of liver disease is very important in all children with chronically elevated liver enzymes. Even if it looks like it might be NAFLD, there's a good chance it may not, and it's important to rule out other causes, as Stephanie pointed out. And as Jeff really nicely summarized, Jeff and Stephanie, the first-line treatment for children with NAFLD and NASH really does remain comprehensive weight management. There really are no proven, validated pharmacotherapy options that we can really turn to at this time. So on next slide, we'd like to now open this up to questions from the participants.
Great. Thank you, Stavra. And actually, if you don't mind, I'd like to pitch the first question back to you regarding bariatric surgery. So someone was interested in your patient that you described with the very severe histology and the psychiatric comorbidities. So would you consider bariatric surgery? Who would you refer, and how young of a patient would you consider?
Well, this is also actually a controversy we didn't touch on, and one that potentially could even be the topic of a whole other webinar, because bariatric surgery itself in children still remains somewhat controversial. We have a very large bariatric surgery program here in Cincinnati, and so we know from having operated over 200 patients that the weight loss effects are very good and well supported. On average, children and teens lose about a third of their weight after bariatric surgery. But the bigger question remains, what is the outcome of NASH and NAFLD after surgery? And there are a number of larger case series in adults that really have shown a dramatic improvement in both fat in the liver and also resolution of NASH. One recent meta-analysis suggested 70% of adults with NASH experienced resolution after bariatric surgery. But again, I think the bar is set very high for whether this is something you should specifically recommend as a treatment for NASH, and the reason for that is that we really don't have any controlled studies to show that it's actually better than lifestyle intervention for NASH. And so have we sent patients, adolescent patients for bariatric surgery? I have sent some patients for bariatric surgery. The issue really for me is that many of these patients have comorbidities. So when they have NASH, often they have other comorbidities that make them eligible for bariatric surgery as well. There are bariatric surgery guidelines out there, expert-based, that recommend considering advancing NASH as an indication for bariatric surgery in a teen whose BMI is 35. So there are a group of experts that advocate this specifically as a treatment for NASH. But those guidelines we referenced earlier from the ACG, AGA, and AASLD do not endorse that recommendation because of the lack of controlled studies. So again, this is a very controversial topic. We have accrued some preliminary pilot data in a prospective observational study of bariatric surgery that suggests that this is likely to be very effective for teens as well. But again, this is uncontrolled, and I think this is a really important research area to explore in future studies.
Thank you so much, Stavra. We have another question which on a different topic. I'll read verbatim the comment posted by the participant. Participant says, you cannot say that biopsy is the gold standard because of sampling error. You would have to compare percutaneous biopsy to an explant or autopsy findings. And also, how will you gauge the degree of cirrhosis, and what would that change in terms of your management of the patient? So I think the question here is, what is the utility of the biopsy? And maybe I direct it towards Dr. Schwimmer.
Thank you. So I think with regard to the issue of sampling error in biopsy, this is something that's really been grossly overstated. So if one looks at the papers that have evaluated this, there is not a difference due to sampling error with respect to diagnosis. So making a correct diagnosis of NAFLD or making the correct diagnosis of an alternative cause for liver disease has never been shown to be at risk because of sampling error. It does affect things like grading the individual features. So this is particularly important for things like clinical trials. And there, what's been shown is that it's a function of biopsy length. So when one has less than 1.5 centimeters of tissue collectively, there is a greater variability in the ability to accurately grade and stage the histology. When one has 2 centimeters or greater of tissue, there seems to be very little variability in the grading and staging of disease. So one of the key messages is to, if one is going to do biopsy, to make sure that the biopsy sample is adequate. As far as the second issue about cirrhosis, I think there's no question that if you diagnose a child with cirrhosis, it influences management. We have children who have died from cirrhosis from NASH. We have children on the liver transplant list with NASH, and being able to look for varices, anticipate the kinds of problems that develop with cirrhosis, help the family to understand and prepare for that aspect of things, as well as beginning the screening for hepatocellular carcinoma, are all important facets of managing patients with cirrhosis.
Great. Thanks, Jeff. So we're getting tons of questions, and so hopefully we can get to a couple more. Stephanie, would you mind commenting on how do you treat NAFLD in a non-obese child? So this happens occasionally in clinic. You get a kid who really doesn't look that overweight, but yet you go through all the steps and they really do have NAFLD.
It's a great question. I think it's a fallacy that's widely accepted around the world. Well, if you're lean, then you're healthy. And I think we've all seen those patients that may be normal weight, but in reality, when you take a diet history, they're eating nothing but junk. They're eating a little bit of it, and so they may have an isocaloric intake for their activity level, but in reality, the carbohydrate load and the fructose intake and other factors that we know are important with the pathogenesis of fatty liver, that those intakes can actually be quite high. Additionally, you can be totally normal weight and be very inactive, and that's still a risk factor for developing heart disease, cancer, stroke, and certainly fatty liver. And I think all of us have seen, especially in certain families, you may see a normal weight individual, but in reality, when you look at their cardiometabolic risk factors, they are elevated and they may have dyslipidemia. So I think that it's not always about weight loss. It also is about lifestyle. And so for me, when I have a normal weight patient in my fatty liver clinic who has biopsy-proven NASH, or, I do actually look at their lifestyle habits. And I have some patients that even go through our formal weight management program, not with the goal of necessarily losing weight to hit a certain BMI goal, but rather to improve the lifestyle habits. Because you can indeed, as you saw in the Nobili paper, you can indeed improve injury, not necessarily fibrosis, but certainly injury in NASH if you can improve the exercise level or activity level and with regards to your actual intake. So I would actually sit down with this family and really educate on the plate method and really follow the American Academy of Pediatrics guidelines on the prevention of obesity in children. You know, the American Academy of Pediatrics has a great website. I think it's very family-friendly. And all of the recommendations to prevent obesity are actually really healthy recommendations that could lead to a change physiologically in our patient who is lean, yet still has fatty liver disease.
Thank you so much, Stephanie. I'm going to try to combine a couple of questions because of the large number of questions you are getting and see if kind of cover a couple of areas together. The participant here asks, what do Native Americans impact in terms of ethnicity in the incidence of NASH within their group? And another question is asking about wherein in the country is highest prevalence of this disease. So I think that the general genre of the questions that I'm presenting would be, what is the ethnic incidence and geographic prevalence of this disorder? Jeff, would you mind taking this on?
Thank you. So with respect to prevalence, for Native American children, there are not published data on that subject. There's certainly anecdotal experience. I know both Steph and I have discussed this in our own patient populations. And certainly we do see that Native American children, it's not unusual that when we see them, they are more likely to have severe fibrosis. As to whether they get NAFLD at a higher rate, there's reason to think that that could be true, but those data just don't exist as of yet. Looking at the country as a whole, we don't have good region-to-region-to-region data, but if you keep in mind that the highest rates are seen in Hispanics, with the next highest rates and almost as high being seen in Asians, white children being high but not nearly as high as Hispanics or Asians, and then African American children being much, much, much lower, you can imagine that depending on the demographics of a given region, based on race and ethnicity, that there are likely to be those differences.
Awesome. Thanks, Jeff. This was a great discussion, and I wish we had more time for questions, but it is time to wrap up. So thank you to our faculty, Dr. Coley, Dr. Zantzikos, Dr. Abrams, and Dr. Schwimmer for an excellent discussion. As we close, I want to again thank NASPGHAN and the NASPGHAN Foundation, as well as Synergiva, our sponsor, for making this webinar possible. As a reminder, the webinar will be available online, so please tell all your friends. And thank you to everyone for attending, and have a great night.